describe the cellular effects of congenital CMV at the level of the cochlea, understand the presentation and progression of hearing loss in these patients, and then recognize some of the hearing rehabilitation options as well as limitations in these patients. So starting a bit broad with a general overview of pediatric hearing loss, approximately 1 in 1,000 newborns are born with bilateral permanent severe to profound sensory neural hearing loss. An additional 2 per 1,000 are born with a mild to moderate loss. And historically, these children were not diagnosed with hearing loss until on average the age of 2, which can lead to significant delays in their speech and language acquisition, can result in poor academic progress, and can have negative social effects on their emotional growth. And so this was until the implementation of universal screening protocols in the 1990s with the newborn hearing screen, which has significantly improved the age of diagnosis in these kids. And so the Joint Committee of Infant Hearing has put out this 136 goal for infant hearing screening. And so the goal is that all newborns are screened for hearing loss by 1 month of age, ideally before leaving hospital. Any child that fails that newborn hearing screen then undergoes confirmatory testing with an auditory brainstem response by 3 months of age, and then any child with confirmed hearing loss is enrolled in early intervention by 6 months of age. And so we're doing pretty well. These are some of the numbers from the CDC from 2019. So 98% of newborns being screened for hearing loss by 1 month. 79% of those that have failed their newborn hearing screen undergoing that confirmatory testing, and then 72.5% of patients with confirmed hearing loss being enrolled in early intervention. So definitely some room for improvement, but in general, doing pretty well. And a lot of centers have actually moved towards a 1, 2, 3 goal. So when we evaluate these patients with a new diagnosis of hearing loss, our workup is going to include evaluation for both acquired and genetic causes of hearing loss, each of which account for approximately 50% of cases. And so our evaluation entails a thorough history of physical exam, looking for any risk factors for hearing loss. And then, of course, CMV testing is always considered, but it does pose its own challenges, and I will get into more detail on that shortly. Confirmation of this etiology of hearing loss is really important for us when we're providing counseling to parents in terms of prognosis, hearing rehabilitation options, as well as for future family planning for both the parents and the child. So focusing on these acquired causes of hearing loss, there are multiple risk factors to be familiar with, specifically maternal torches infections and CMV. So CMV is the most common cause of acquired congenital hearing loss, accounting for up to 25% of cases. Other risk factors to kind of be aware of, neonatal meningitis, antibiotic use, a NICU stay, prematurity, or need for mechanical ventilation, and ECMO. Okay, so this is the first Slido question. We'll leave this up for a second. Okay. Should I advance it again?
Yeah, because it'll show up again.
Okay. I think that's pretty good. Okay, so a little bit of variety here. So the answer is 0.5%. So CMV is a double-stranded DNA virus. It is a member of the herpes viridae family, and it is very, very common. So an estimated 50% of the population in high-income countries is affected by adulthood, and almost 100% of the population in lower-income countries is affected by adolescence. In industrialized countries, it affects about 0.5% of newborns, but up to 6% of newborns in developing countries. The risk of intrauterine transmission from mom to fetus is highest with a maternal primary infection and with older maternal age, but transmission can also occur with reactivation of a previous infection or infection with a secondary non-primary strain. That rate of transmission can be as high as 32% during a primary infection compared to as low as 1% with a non-primary infection. And then the highest risk of fetal anomalies is going to be if mom is infected either around the time of conception or during the first trimester. So to put these numbers into a little bit of perspective, there are approximately 80,000 live births in Arizona annually. And so about 400 of these newborns are going to be infected with CCMV, and then 120 of these patients are going to have long-term sequelae. Okay, next slide question. Sorry. So which of the following, if found in a newborn, should prompt CMV testing? Choose as many as apply. Microcephaly, blueberry rash, Hutchinson teeth, low birth weight, and so yes, all of these, except for Hutchinson teeth, should prompt testing for CMV. So congenital CMV can be characterized as either symptomatic or asymptomatic at birth. Thankfully, most newborns are asymptomatic at birth. However, historically, this did also include patients with sensorineural hearing loss. And so as definitions are evolving, this number may actually be slightly lower. About 10 to 15% of these patients are going to develop long-term sequelae, the most common of which is sensorineural hearing loss. The other 10 to 15% of newborns will be symptomatic at birth, and these patients tend to have poorer long-term neurodevelopmental outcomes, and up to 50% of them will have long-term sequelae. And then there is a 5% mortality rate in these patients. Severity is then further classified depending on the number of manifestations that may be present and whether or not there's any central nervous system involved. And so these are some of the common manifestations of CCMV. So small birth weight, microcephaly, blueberry muffin rash, jaundice, hepatosplenomegaly. Central nervous system involvement can present with lethargy, hypotonia, and seizures. There are several abnormalities that can be seen on neuroimaging, which can be suggestive of congenital CMV as well, if the diagnosis isn't already confirmed. There are also multiple ophthalmologic abnormalities that can be present, and so opto evaluation for all of these patients is warranted. And then, of course, these patients can have unilateral or bilateral hearing loss. So just a few examples of the blueberry muffin rash, jaundice, and then microcephaly here. In terms of radiology, so there have been a spectrum of radiographic findings that have been described, encompassing both intracranial and whole body findings. So as I mentioned, neuroimaging can reveal some of these classic findings of CMV, and it can help to determine the severity of the infection. So intracranial findings that are specific to CMV include temporal lobe lesions, ventriculitis, and intracranial calcifications. Some of the more non-specific findings include ventricular septations or pseudocysts, ventriculomegaly, and then white matter changes. And so these are a few examples of some of these findings. So a CT head showing the very classic intracranial calcifications. And then these next three images are all from a fetal MRI. So this first one is showing ventriculomegaly. This next image here is a sagittal MRI showing the dashed arrow is showing third ventricle dilation. The non-dashed arrow is showing cerebellar hypoplasia, and then the arrowhead is showing skin edema. And then lastly, again, we're seeing ventriculomegaly and these intracranial calcifications. So moving forward to diagnosis, so as I mentioned, this is the most common congenital infection causing hearing loss, and it can have significant long-term sequelae for patients. And so early diagnosis and potential screening options are really important to ensure that treatment is initiated in a timely manner if it is an option. And so the diagnosis of congenital CMV can only be made before the baby is 3 weeks of age. Otherwise, it's essentially impossible to distinguish between a congenitally acquired infection versus one that was acquired postnatally. Urine and saliva cultures are the gold standard, but cultures can be expensive, timely, and subject to contamination in the lab, so we don't actually use them. We do use saliva, and if saliva samples are being obtained, they should be not obtained immediately after birth, and at least an hour should be allowed to pass after breastfeeding. And so instead we use PCR because it's lower cost, it's faster, and it's easier to maintain. And so this was a study published in 2011 comparing rapid culture with both liquid and dry saliva PCRs. And so they enrolled 35,000 newborns. All of them had rapid cultures done, and then half of them had liquid saliva PCR, and then the other half had dry saliva PCR. And you can see that the sensitivity, specificity, and both positive and negative predictive value were high for both liquid and dry saliva. And so currently, for any patient that is under 3 weeks of age, and there's a concern for congenital CMV, diagnosis can be made with saliva PCR followed by confirmatory testing with urine PCR. So what if you're not able to test these kids within 3 weeks? As I mentioned, you can no longer use their saliva or urine. And so this is where the dry blood spot can potentially come into use. Okay, so how long does Arizona keep their newborn dry blood spot? 30 days, 90 days, 1 year, 2 years. Yes, so 90 days is how long Arizona keeps their dry blood spot. Okay. All right, yeah, so that was the last slide of the question. Okay, so the dry blood spot is a screening tool. It's already used to screen for a variety of metabolic and genetic diseases. So in theory, it should be easy to acquire. Unfortunately, the amount of time that the dry blood spot is kept is state specific. And so as you can see, there's a pretty wide variety in how long each state keeps it. Arizona holds on to it for 90 days, which is kind of on the lower end of the spectrum compared to some other states, some of which actually hold on to them indefinitely, which is unfortunate because it is a good tool to use when kids are presenting past the 3 weeks of age. So a few studies have been done to assess the sensitivity and specificity of the dry blood spot compared to saliva PCR. Some of these earlier studies actually showed a fairly low rate of sensitivity, so not thought to be a great screening tool, but the specificity was high, and so certainly beneficial for targeted hearing or targeted testing in kids who are presenting with hearing loss and are older than that 3 weeks of age. One of the more recent studies actually had a fairly high sensitivity as well, and so as these tests are just getting better and better, these numbers are only going to improve, and maybe it can be used as a screening test one day. But as of right now, still a good option for evaluating patients who are either just past the 3 weeks of age or in kids who are presenting in a delayed fashion at 3, 4, 5 years of age if they're in one of these states that holds on to them. Okay, so focusing more now on hearing loss in CMV patients. Overall, there is a 10 to 15% risk of developing sensory neural hearing loss. And this risk is highest in patients who are symptomatic at birth. However, there is a wide variety in that presentation. And so while some patients will have hearing loss at birth, as I mentioned, others will present in a delayed fashion. Hearing loss can be unilateral, it can be bilateral, it can be stable, progressive, and even fluctuating. Most patients are going to present before 6 years of age. And so it's really important to follow these kids with routine audiograms if they are found to be positive for CMV at birth, but initially had normal hearing. These kids who are presenting in a delayed fashion typically will present with a unilateral loss or single-sided deafness. And so even though they're not likely to have the same degree of trouble with speech and language acquisition as their peers with bilateral hearing loss, we do know that kids with single-sided deafness do have trouble with the sound vocalization, trouble with hearing in noisy environments. And so it is important to monitor these patients and make sure that they're getting proper hearing rehabilitation in a time. Okay, so next I just wanted to take a few minutes to discuss some of the cellular level effects that CMV has on the cochlea to help us better understand why these kids are developing hearing loss. So this was a study done out of the Hospital of Sick Children in Toronto, illustrating the damage that CMV has on the cochlear vasculature. And so 25 mouse models were included in the study to compare both cochlear function and vasculature in those inoculated with CMV compared to controls. So their mouse models were inoculated with CMV on postnatal day 3. Cochlear function was assessed at week 6 using auditory brainstem responses and photoacoustic emissions. And then they assessed the cochlear vasculature at week 8 using these corrosion casting models. And so if we look at the results here in both the ABR testing and the OAE testing, the CMV patients had significantly higher hearing thresholds at all 3 of the tested frequencies compared to the control patients. And then on average, the ABR thresholds were higher in the CMV patients compared to controls, as were the OAE thresholds, signifying that these models did have hearing loss compared to the controls. And then if we look at the vascular castings that they created, we can see the differences in the cochlear vasculature in the CMV models compared to the controls. So there are 3 main vascular beds that supply the cochlea. The stria vascularis and the spiral ligament are located within the wall of the cochlea and are oriented perpendicular to one another. So those are the ones that we can see nicely in figure A. And then the spiral limbus is situated more centrally and is the blood supply to the spiral ganglion cells. The stria vascularis located in the wall of the cochlea also is responsible for creating the endocochlear potential between the different compartments of the cochlea, which is required for depolarization of the hair cells and ultimately activation of the auditory nerve. And so the hypothesis is that damage to this vascular supply is leading to disruption of the endocochlear potentials and ultimately hearing loss. So they found a wide range of damage between the mouse models, despite all of them being inoculated with the same protocol, which is similar to kind of what we see clinically with a wide variety in presentation. And so these 4 images here, so image A, this is a normal control. So again, vessels oriented perpendicular to one another within the wall of the cochlea. In image B, we can see that the horizontally oriented vessels have narrower diameter compared to those in A. In image C, we're looking at the apex of the cochlea, and we can see damage to the vessels both in the wall as well as more centrally located in the spiral limbus. And then in image D, this is just a widespread loss throughout the entire cochlea. Okay, so then they performed a follow-up study to demonstrate that the endocochlear potentials were in fact reduced in these CMV models and that it correlated with poor cochlear function. And so if we look at the results here, the control patients on average had a higher endocochlear potential compared to the CMV models, with an average of 75 in the controls versus 32 in the CMV patients, and a normal endocochlear potential is around 80. And so then they took it one step further to correlate those endocochlear potentials with the ABR thresholds. And so we can see that there's a reverse correlation between the endocochlear potentials and the ABR threshold. So as the potentials are going down, those ABR thresholds are in fact going up. Okay, so turning things back to some of the more clinical manifestations of CCMV, as I mentioned, hearing loss can manifest with a wide variety in presentation, and so it's important to understand how these hearing thresholds can change over time. So this was a study done out of Belgium, published in 2016. They performed a prospective multi-center study over 7 years, including all patients with documented CCMV who had at least 2 audiologic evaluations and were followed until the age of 6. So they had 379 patients in total, 123 were symptomatic, 256 were asymptomatic. Their definition of symptomatic did include hearing loss, so by definition, any patient that had normal hearing at birth was asymptomatic, as long as they had no other manifestations. And so in terms of their findings, so 61% of the patients who were symptomatic for CCMV had hearing loss at their initial evaluation, compared to 0% in the asymptomatic group by their definition. 27% of those patients with normal hearing in the symptomatic group went on to develop delayed onset hearing loss, compared to 8% in the asymptomatic group. So a 3 times greater rate of delayed onset hearing loss in the symptomatic cohort versus the asymptomatic group. And then if you look at ears specifically, so 26% of ears that already had some hearing impairment at birth had a progressive loss, compared to 11% of ears that had normal hearing at birth. So 2.5 times greater rate of progression of that hearing loss in ears that are already impaired at birth compared to normal hearing ears. And both of these numbers were higher in that symptomatic group. Okay, so this next study, a little more recent retrospective chart review out of Boston. So they included patients who had, again, confirmed CMV and a unilateral loss at birth, and had at least 3 audiologic follow-ups. So overall, they had 32 patients included, 15 of which were symptomatic at birth, and their definition was symptomatology other than hearing loss. So if we look at their normal hearing ear, so again, all these patients have hearing loss in just 1 ear at birth. And in normal hearing ear, 12.5% of them went on to develop hearing loss. All of these patients were symptomatic, and most of these losses again occurred within the first 5 years of life. And then if we look at the hearing impaired ear, so 8 of those patients already had a profound loss at the time of presentation, and so they were excluded from any progression analysis. But of the remaining 24, 71% of them went to develop progression of their hearing loss. So this number is, much higher compared to what the last study was showing, was 26%. But it's hard to compare these studies just given all the different inclusion criteria that they have and other comorbidities that these patients may have. And then lastly, so this was a longitudinal study, so with 18 years of follow-up out of Baylor. So these patients were screened for CMV as part of a larger study that they were conducting, and then they were enrolled in this study for hearing evaluation and follow-up. So they had 92 asymptomatic CMV patients and 51 controls who were born within 6 days of those CMV patients. They defined any hearing loss that was present within the first year of life as congenital or early onset. So overall, 9 patients, or 10%, were found to have congenital sensorineural hearing loss. An additional 3 patients developed hearing loss by the age of 5, so 60% in total. And then within the remaining 13 years, only 8 additional patients developed hearing loss. So again, the majority of these patients are presenting before 5 years of age. 50% of them had unilateral loss, 50% had a bilateral loss. And then again, if we look at the proportion in total, 10% had a congenital loss. And then overall, 25% had hearing loss over the 18-year period, but the increase in the hearing loss from 5 to 18 years was not really significantly different than the proportion of patients that also developed hearing loss in the control group. And then, so again, looking at progression of loss, so in those 9 patients that had a congenital loss, or an early onset loss. Only one of them had bilateral hearing loss. And so of the remaining 8 patients, 75% of them went on to develop hearing loss in the contralateral ear, compared to only 14% of patients who had normal hearing at birth developing hearing loss. Kind of illustrating the risk of hearing loss in the contralateral ear is 6 times greater in a patient who already has a unilateral loss compared to develop hearing loss in a normal hearing ear. Okay, so that was a lot. So kind of summarizing that, majority of hearing loss is going to present within the first 5 years of life. The risk of hearing loss is greater in patients that are symptomatic at birth. And then the risk of hearing loss progression is also greater in symptomatic patients. The risk of losing hearing in the contralateral ear is up to 6 times greater in patients who are born with a unilateral loss, compared to developing any hearing loss in patients who are born with normal hearing. So in considering hearing rehabilitation for these patients, these are some of the main principles that we keep in mind. I kind of already touched base on the first 2, but so hearing aids and cochlear implants are going to be the mainstay of hearing rehabilitation for these kids. An estimated 30 to 65% of patients that are symptomatic will require hearing amplification, and 2 to 14% of patients that are asymptomatic will require hearing amplification. And then similar to kind of everything else that we've seen, the rates of cochlear implant are greater in those that are symptomatic, although as candidacy guidelines are changing for patients with single-sided deafness, we may see some changes in these numbers. So in general, cochlear implants are indicated in pediatric patients who have bilateral profound sensory neural hearing loss and are not going to benefit from hearing amplification alone, or patients that have bilateral severe loss and are having limited benefit from their hearing aids in terms of speech and language acquisition and development. Recently, cochlear implants were approved for pediatric patients with single-sided deafness over the age of 5. And then different from the adult world, cochlear implants in the pediatric patient is very much not a kind of one and done procedure. There is an extensive post-op speech therapy requirement for kids and families. And so it's really important in counseling these families that kind of what the expectations are after surgery. And then, as is true for all cochlear implant candidates and implantees, consistent use is critical for optimal outcomes. All right, so in the next couple of studies that I'm going to reference, there are a lot of different hearing assessments that they talk about. And so I just wanted to review a couple of them so that we're kind of all on the same page as we're looking through those studies. So the first one, Infant Meaningful Auditory Integration Scale. It's a series of 10 questions for parents regarding their child's spontaneous listening behavior. So it's kind of a subjective evaluation of how they feel their child is doing in terms of vocalization behavior, spontaneously alerting to sounds and speech, and then being able to derive meaning from sound. The multimedia audiologic test is similar to word recognition testing, where sentences are read of men, women, and children to assess the child's speech understanding. Speech intelligibility rating is a scale used to measure the intelligibility of the words spoken by the child. And then the categories of auditory performance is a nonlinear scale of 10 categories that assesses a patient's ability for auditory perception. So these are, again, just kind of what these assessments look like. So for the Meaningful Auditory Integration Scale, parents are asked these 10 questions regarding their child's spontaneous responses to their own name, in quiet situations, in noise, how they're responding to sounds in the environment, and then kind of their ability to interpret different sounds, speech, distinguish tones, and things like that. The speech intelligibility rating has 5 categories ranging from single word intelligibility to connected speech being intelligible for all listeners. And then this category of auditory performance has 10 categories ranging from no awareness of environmental sounds to understanding some words, some phrases, to understanding conversations without lip reading, and then lastly, being able to engage in a telephone conversation where there are no visual cues. Okay, so looking at a few of these studies, so this first one was a retrospective chart review published in 2017 out of London. They had 11 patients included. Mean age of presentation was 1.7 years old, and the mean age of implant was 2.5 years old. So for their hearing outcomes, they used the categories of auditory performance, the speech intelligibility, and then that parental questionnaire. And so obviously this is a pretty small group of patients, and so it's hard to make any concrete conclusions from it. But we can look a little closely at kind of how each of these individual patients did. So overall, 9 patients had abnormal MRI findings. 4 had neurologic abnormalities, and then 3 had neurocognitive impairments. And so in terms of results, there were mixed results. So the first 5 patients, who only 3 of them had abnormal MRI findings, all did pretty well. You can see the CAP scores are in category 9. Speech intelligibility was at the highest with 5 in 3 of the patients. And then they all did really well in that questionnaire by the parents. The next group, not as well. So we can see that this group of patients did have much more abnormal findings in terms of neurologic developments, neurocognitive impairments, MRI findings, and so they didn't do as well. Some improvement in their scores, but overall not as good as the first group. And then this last group, really did not find much benefit from their vocal implants at the time. So just kind of reiterating that there's such a wide variety in the presentation of these patients, and so that's why it's important to identify the best candidates for implementation. So this next study, again, a retrospective review out of Japan, comparing 16 children who had CCNV and underwent cochlear implantation with patients who underwent cochlear implantation for non-CMV reasons. And so they compared their hearing outcomes and then their speech and language production and perception. And so again, this is kind of a detailed summary of the CMV group. So these red starred patients, so you'll see in the next few slides, I kind of mapped them out for us so we can follow them along. So the red stars are patients that had no cognitive delays and no brain abnormalities on imaging. The blue star patients are patients that had cortical dysplasia on their MRI. And so we look at outcomes. So these are the outcomes for recognition and speech discrimination in the CMV group. So overall, they did fairly well, and mixed results in terms of even patients that had no MRI or neurocognitive abnormalities. And then if we look at the results compared to the non-CMV group, the non-CMV group did do better in terms of their average word recognition and speech discrimination scores. And then if we look at their speech perception and speech production, they use this developmental scale to kind of assess where the child is 5 months, so similar to developmental milestones. And so the lines on these graphs represent the CMV group, and then the scattered diamonds represent the non-CMV groups. So all of the CMV patients did have improvement in both their speech production and perception. But as you can see with long-term follow-up, the difference between those that did well and those that did not do well became really stark and much more clear. In terms of comparing them to the non-CMV group, there was no difference in their perception and production within the first year after implantation, but by year 2 and 3, the non-CMV patients were performing better. And that's kind of illustrated here as well. So in terms of both production and perception, preoperatively and within 1 year, the CMV patients were pretty much in line with the non-CMV patients. But then as we're getting into year 2 and 3, the non-CMV patients did tend to do better in both speech production and perception. And then lastly, this last study, another retrospective review published in 2021 out of Quebec. So they included, again, patients that were CMV positive with congenital deafness, and then they case matched them for gender, age of implant, and type of hearing loss in non-CMV patients. And so we can see, so this was their cohort here. So no differences in gender, the type of hearing loss in terms of whether or not it was profound at birth or progressive, and then the age of implant. And so we know that kids that are getting implanted earlier are going to tend to have better outcomes compared to kids that have longer times of auditory deprivation. And so I think this is a really good marker that they matched for. And so if we look at their outcomes, so they used that multimedia audiometric test as well as the parental questionnaire. And so for the multimedia audiometric test, so no difference between the two groups preoperatively, which I would expect. But postoperatively, the control group did have higher scores compared to the CMV group, as well as a greater difference in their pre and post score compared to the CMV group. In terms of the questionnaire, so no difference preoperatively or postoperatively. And so while objectively the control group was doing better in terms of subjective improvement noticed by parents, there was really no difference. And then lastly, they compared outcomes in the CMV group based off of the MRI severity and whether or not there were any neuropsychological disorders as well. And they found no association between the severity of MRI findings and hearing outcomes. And they also found no association between the presence of any neuropsychological disorders and their hearing outcomes, although there was a trend in that direction. So kind of summarizing that, cochlear implants, they are advantageous for patients with CCMV with hearing loss and new criteria, although these results may not be as good compared to counterparts that are having either idiopathic hearing loss or genetic causes of hearing loss. No correlations that were shown on these studies between MRI severity and the presence of neuropsychological disorders with hearing outcomes, but I think with larger powered studies that will actually pan out. And then for each patient that's being considered for a cochlear implantation, an individualized plan needs to be created considering a lot of the non-medical factors. So as I mentioned earlier, age of implants, patients are going to do better. We know that kids that are using their implants are going to do better. So making sure that there's a lot of family support and buy-in, and that they're going to kind of encourage their kid to keep their implant. And then, so this last thing, so there may be a benefit of antiviral therapy in improving hearing outcomes, and we'll just spend a few minutes talking about some of the treatment studies that have been done. So treatment of CCMV is largely driven by symptomatology. Initial studies were done with IV ganciclovir, and then later studies looked at oral valganciclovir due to lower risk of side effects, which include in the short term neutropenia, thrombocytopenia, and hepatotoxicity. A lot of these short-term side effects do typically reverse after medications are discontinued. And so the current AAP recommendations are for treatment of patients that are symptomatic, greater than 32 weeks gestation, and for whom treatment can be initiated within 4 weeks of age. So these are a few older studies that were kind of investigating different treatment protocols in terms of medications, length of treatment, and things like that. And they reported on hearing outcomes as well. And overall, their early results were actually pretty promising for improved hearing outcomes in patients that were treated compared to controls. Now, those studies, even though the results were promising, they were being conducted in a very specific subset of patients, patients that were symptomatic other than hearing loss, were greater than 32 weeks gestation, and for patients who treatment could be initiated within 4 weeks. So these are a few of the more recent clinical trials that have been started investigating outcomes in patients outside of those criteria. So the first one looking at outcomes in terms of hearing loss in patients that are being treated outside of the first month of life. And then the second two looking at outcomes in patients who are asymptomatic except for hearing loss. These first two studies are actually both completed. The results of the first one are not published yet. Looking through their data preliminary, it didn't look like there was an effect on improving hearing. And then the second one was ended early because they only recruited 7 patients. And this third one is still recruiting patients. So I think definitely more to come in terms of treatment options for patients who are asymptomatic, other than hearing loss. And then lastly, just a few words on vestibular dysfunction in these patients. So the true prevalence really is not known of vestibular dysfunction in CCNV patients. Some studies have reported higher rates of vestibular dysfunction compared to sensory neural hearing loss, but this was a recent systematic review published last year. And so the prevalence really quite a range, so 14 to 90% reported in some studies. And then similar to kind of everything else that we've seen, more common in symptomatic patients compared to asymptomatic patients. And similar to hearing loss, a wide variety in presentations. So can be detected as early as 3 months, seen in patients who have otherwise normal hearing, and can be progressive similar to hearing loss. And so patients who do have confirmed CCNV should kind of be monitored a little more closely for vestibular dysfunction and potentially undergo vestibular testing screening if available at the institution. And similar to kids who are presenting with delayed onset hearing loss, and when we think about potentially doing that dried blood spot testing on kids who are presenting with vestibular imbalance dysfunction in a delayed onset, should potentially be considered for CNV testing as well, if the blood spot is still available. Okay, and then so just a couple of future directions and kind of things to come. Hearing targeted CNV screening is not really a future direction, so something that is happening now. So starting back in 2013, Utah had established a mandate to perform CNV testing on all newborns that failed their newborn hearing screen within 3 weeks of life before they kind of age out of that test. And so now over 130 hospitals are doing targeted screening in that way. Minnesota, starting this year, had actually started universal screening for all patients, not just those that are failing newborn hearing screens. And then, as I mentioned, I think as some of these more studies are being conducted, I think we'll start to see treatment for patients who are otherwise asymptomatic that have hearing loss. If there's any questions, if there are any. Yeah.
My experience, we don't do any emergency cases where I discharge. They
Yeah.
and then they fail, and yeah.
Yeah, so I think, unfortunately, hearing is often kind of put on the back burner in the NICU patients. And so if they're not getting their hearing screened within the first 3 weeks of birth, then we're not going to be able to test them with urine and saliva. But that is where that dried blood spot can potentially come into use. Great, well, thank you all.
What's the youngest age at which you are putting program?
So the youngest that I've seen has been, I think, 7 months, but you can do it as early as 6. You want to ideally do it before 1 year of age.
Okay.